Good evening, everybody. Welcome to this evening episode of Puruse. This is Puruse 7K Neuropathology, and we are streaming live from NIMHANS, Bangalore via Kolkata. And today we have a very special topic and a very special person to speak on that topic. The topic of the day is Immunohistochemistry and molecular profiling of brain tumors. And we have somebody who's an expert in that. We have Dr. Shilpa Rao, who's a postgraduate from JIPMER, Puducherry, a gold medalist from there, and the first DM Neuropathology in NIMHANS, Bengaluru, with numerous publications in national and international journal. She's also a DBT Wellcome Trust Early Career Fellow. And before I ask Madam to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Shilpa, ma'am, please share your screen and start. Thank you.
Yeah, thank you, sir, so much. And good evening, everyone. Am I audible?
Absolutely clear.
Okay, thank you so much. So we'll start today's lecture, which is going to be on immunohistochemistry and molecular profiling of brain tumors. So it would be practically difficult to cover all the brain tumors in a single session. So what I'll be doing in this 1 hour is take you through the molecular profiling of some of the common brain tumors that we encounter in day-to-day neuropathology practice. First of all, why do we need to know about immunohistochemistry and molecular profiling of brain tumor? All of us know that the CNS tumor classification has evolved over time from the earliest Bailey and Cushing classification, which came up in 1926, which was mainly based on the histogenetic profile of any tumor. The cell of origin was based on how the tumor cell resembled its normal counterpart. Later, 4 WH editions have come. Though the initial editions again concentrated on the histological typing of CNS tumors, later on immunohistochemistry was introduced. However, molecular component of the classification came into effect only because of this important meeting held in Harlem, where several neuropathologists and clinicians came up with the ISN Harlem consensus, which recommended that molecular data of CNS tumors be incorporated into the CNS classification. So this formed the basis for the current 2016 revised 4th edition of CNS tumor classification, which we are all following right now. However, we are headed towards the 5th edition of CNS tumor classification, which is expected to be released this year, and that is going to be mainly based on the moleculars of CNS tumor. So since we are currently following the 2016 classification, I am going to be describing all the tumors with respect to this classification, with of course additional information with respect to each individual tumor group as well. So why at all did this 2016 classification come up? I said that in ISN Harlem, whatever meeting happened, they came up with a consensus that molecular be incorporated into the classification. Why did this happen? This actually happened because of 2 reasons. One, there was a lot of subjectivity in the way that CNS tumors were diagnosed and especially graded. So there was a lot of variation between the grade that I gave and somebody else gave. So what the group said was, it's better to incorporate moleculars with morphology in order to remove the subjectivity and have an objective way of classifying and grading CNS tumors. The other important reason behind the change was, it was felt that the morphological classification alone was not giving a clear picture about the clinical behavior of the tumor. That is the reason why morphology and moleculars were combined and an integrated diagnostic approach was put forth in the 2016 classification, which has of course brought about a radical change in the way we diagnose CNS tumors and classify CNS tumors. So what are the different methods one can use to identify these molecular alterations? First and foremost is our favorite immunohistochemistry, which can help us in assessing a lot of genetic alterations provided the antibody is available. Why is it so favorite for all of us? Because it's a very simple technique available across most labs and hospitals right now. It is also cost effective and the turnaround time is less when compared to any of the other molecular techniques available so far. So for genetic alterations where immunohistochemistry is not available, what can we do? We can do Sanger sequencing where we can detect a lot of single nucleotide mutations. So Sanger sequencing followed by even fluorescence in situ hybridization is a common technique which many of the labs are coming up with, and this fish can help us detect copy number alterations. So, but in comparison to immunohistochemistry, these two techniques are more time consuming. They need specialist or trained technical staff, and also you need to have certain instruments. For Sanger sequencing, you need a sequencer. For fish, you need a fluorescent microscope to visualize and interpret the results. You also need expertise to interpret all these results. So there is some kind of disadvantage to use all these techniques in a day-to-day practice. Further, we also have high throughput techniques which are coming up in routine practice as well in several laboratories. That is the next generation DNA sequencing as well as DNA methylation profiling, which is the latest which has entered into this platform. So let us see how all these platforms can be used for day-to-day diagnostic and prognostication of CNS tumors. For any CNS tumor that we are looking at, what are the basic diagnostic marker any pathologist should use? First, we need to know the lineage of a tumor. Then we can go into its moleculars, we can go into its classification. So if we want to determine the lineage of a tumor, for glioma, this is the basic panel that we could use. A GFAP, OLIG2 and S100 will help us in telling that it is a glioma. MIB1, of course, for any CNS tumor will help us in determining the grade of the tumor. It will only be complementary to the mitotic activity. In no tumor should be used MIB1 alone to grade any CNS tumor. Okay. So these are the markers which can be used for glioma. What about synaptophysin? Synaptophysin can be used to determine the embryonal tumors as well as glioneuronal tumors. So these are the broad categories of tumors which are most commonly encountered. One is glioma and the other is embryonal tumor. Similarly, we have mesenchymal tumors. For mesenchymal tumors, the most common being meningioma, we could use Vimentin and epithelial membrane antigen. So this is just a very basic foundation markers. I'll also tell you how these markers are helpful within glioma itself. So I'll give you a few examples here. You can see in this picture on the top, this is GFAP in a diffuse glioma, whereas this is GFAP in an ependymoma. If we don't have an idea why we need to or how we need to use this to distinguish these two tumors, we will just say that GFAP is positive in tumor cells in both the pictures here. But what one needs to identify is, in a diffuse glioma, you can see that the tumor cells are intensely positive and the stroma is also intensely positive. There is a diffuse pattern of staining. Okay, whereas in an ependymoma, here what we are seeing, around the vessels, as you all know, ependymomas are characterized by perivascular pseudorosics. So around the vessels, whatever fibrils are there, they tend to take up an intense GFAP staining, resulting in what is called as perivascular accentuation pattern in GFAP staining. So this helps us in distinguishing between a diffuse glioma or even a circumscribed glioma will have a diffuse intense staining. Circumscribed meaning Spilocity Gastrocetomas. So they will also have this pattern of staining, whereas ependymomas usually have this perivascular accentuation, which helps us in distinguishing these two tumors by using a simple IHC stain. Next we have a OLIG2. So this OLIG2 tends to produce nuclear immunopositivity, again in a diffuse glioma. By diffuse glioma, it could be Astrocytoma, Oligodendroglioma, or even a Glioblastoma. So all these tumors and circumscribed gliomas like Spilocity Gastrocetema, all of them show diffuse positivity for OLIG2. Whereas in an ependymoma, what happens is either there is complete absence of OLIG2 expression or there can be only patchy OLIG2 expression. So again, this staining helps us in differentiating between ependymoma and other gliomas. MIB1, as I already told you, helps us in grading tumors, which is complementary to mitotic activity, which is identified on a HMV routine stain. What about epithelial membrane antigen? So, epithelial membrane antigen can be used as a diagnostic marker in ependymoma as well as meningioma. But there is a difference in the pattern of staining. In ependymoma, we see what I am showing you here. These are the paranuclear dot positive stain. So this is classically seen in an ependymoma, whereas when you see a meningioma, it should be a membranous stain. So even though these are very basic markers, these are very important for us to form a foundational understanding. After this only we can move to the next step of understanding how immunohistochemistry can be used for molecular profiling of all these brain tumors. So the first group of tumor that we are going to look at today is diffuse glioma, because it's one of the most commonly encountered tumors and has a lot of role of moleculars in its classification and prognosis. Here I have put the 2016 WHO classification of diffuse glioma, which includes astrocytic as well as oligodendroglial tumors. What is most important here is that each and every tumor, be it astrocytic or oligodendroglial, of any grade, grade 2, grade 3 or grade 4, everywhere what we see is the tumors are classified as IDH mutant or IDH wild type. That tells how important IDH itself is in the classification and diagnosis of CNS tumors. This IDH mutation was identified in 2008 when Von Demling and his group analyzed IDH mutation in a large group of brain tumors and said that the tumors which showed mutation had a good prognosis. So that is the main reason why it has found its place in the classification of all diffuse gliomas in the CNS tumors. So that is one important point that you need to know. The second important point is, if you see, look at oligodendroglioma, be it grade 2 or grade 3. In addition to being IDH mutant, these tumors should and must show 1p19q co-deletion. So that is an additional molecular marker that we need to look at when we are seeing any oligodendroglioma. What is the other change? There is a variant in IDH wild type glioblastoma that is called as epithelial glioblastoma, which also is based on its morphology as well as its molecular characteristics. Then there is a very important tumor here, which is a distinct entity in itself, which is termed as diffuse midline glioma, H3K27M mutant. We will be looking at these tumors in further slides. So, for basic understanding here, I have put up the algorithm which WHO 2016 edition itself came up with. Here you can see the first tier of classification is based on the histology. It could be astrocytic, oligodendroglial or oligoastrocytic tumor. All these tumors, we need to look at three important markers. One is the IDH status, whether it is IDH mutant or IDH wild type. The second important marker is ATRX and P53 mutation. And the third important one is 1p19q co-deletion. So based on this, the tumor definition goes like this. Oligodendrogliomas are always IDH mutant and 1p19q co-deleted. Astrocytoma, on the other hand, can be IDH mutant or wild type, but it should not show 1p19q co-deletion. So These tumors are 1p19q non-co-deleted. What about tumors for which moleculars has not been performed? Such tumors can be categorized as not otherwise specified. So now we have three important molecular markers, that is the Idh mutation, ATRX mutation and 1p19q co-deletion. Let's learn a few important points about each of these molecular alterations. The first important molecular alteration is IDH. So IDH stands for isocitrate dehydrogenase. IDH not only has diagnostic significance in CNS tumors, it also has prognostic significance and therapeutic significance. So diagnostic point of view, how does IDH help us? If a tumor shows IDH mutation, then it is definitely a diffuse glioma. So you can use it to differentiate diffuse glioma from any circumscribed glioma like Spilocity Gastrocetema or a pleomorphic xanthoastrocytoma. And you can also use it when you are in doubt whether the biopsy is representative of reactive gliosis or it is a diffuse glioma itself. So once you see IDH positive or IDH mutant cells in a biopsy, you are sure that it is a diffuse glioma. It could be an astrocytoma or an oligodendroglioma. How do we detect this IDH mutation? IDH itself has three isoforms. You have IDH1, 2 and 3, amongst which IDH1 and 2 are mutated in CNS tumors. IDH3 mutation is not detected till now. And amongst these mutations, more than 90% of the mutations are IDH1 R132X. So we are lucky that there is an immunohistochemical marker available to detect this particular mutation. So how does this cytoplasmic staining? So we should look at specific cytoplasmic staining. What about the rest 10% of the tumors which do not show this IDH1 R132H, that will not be detected by IHC? So for that particularly we need to do PCR followed by sequencing, where we can detect presence of the heterozygous mutation. Other than R132H, we can get R132C and R132S and so on. Similarly, in IDH2, there is alteration at the R172 position. So all these need PCR for detection, and it is seen in about 10% of diffuse gliomas. The next important marker that we need to use for any diffuse glioma is ATRX, which stands for alpha thalassemia mental retardation X-linked. It was first identified in these syndrome, so it was called as ATRX. Further, after that, a lot of other tumors have shown ATRX mutation. What does it mean to us when we are looking at brain tumor? So whenever there is an ATRX mutation and we do IHC, unlike other immunohistochemical marker where we look for positivity, here we look for loss of expression. So whatever brown we are seeing here, positive cells, these are the internal control cells. Here we are seeing endothelial cells, some lymphocytes and microglial cells. So all the normal cells will express ATRX. Again, it's a nuclear marker. Any cell which has undergone ATRX mutation will show loss of expression. So once there is a loss of expression, what does it mean to us? Loss of expression tells us that this tumor is astrocytic in origin and ATRX is always mutually exclusive with 1p19q co-deletion. So ATRX mutation will not be seen in any oligodendroglial tumor. If there is a ATRX loss, it definitely tells us that it is astrocytic. Next, it can also be seen in a subset of histone mutant tumors, about which I will be telling you in detail in a short while. So we have learnt about IDH mutation, we have also learnt about ATRX mutation. For these two, most commonly we use immunohistochemistry. What about 1p19q co-deletion, which is a very important marker again, which is diagnostic of oligodendroglioma. Without showing 1p19q co-deletion, we cannot call any tumor as oligodendroglioma. So it is not only diagnostic marker, it also has prognostic and predictive value. What does it mean? Any tumor which shows 1p19q co-deletion is supposed to behave well. These patients have better prognosis when compared to diffuse gliomas which do not show 1p19q co-deletion. And also these patients respond well to treatment with chemotherapy. So that is why it has a predictive role as well. How do we identify this 1p19q co-deletion? We do not have immunohistochemical marker for this. So we need to depend on fluorescence in situ hybridization. So we are looking at two different chromosomes. One is 1p and the other is 19q. So we need to use two different probes, and the test probe also needs to be accompanied by a control probe for us to be able to compare with the control and say that there is indeed deletion. So in general, green signals indicate the control probe and the red signals indicate a test probe. So we count about 100 nuclei, like how we count for Ki67 or the Mgmt labeling. Even for 1p19q, we count about 100 nuclei and we take ratio separately for 1p and for 19q. The cutoff taken is 0.8. If the ratio is less than 0.8 of green to red signals, then it is taken as deleted. Remember that both 1p and 19q should show deletion for us to diagnose any tumor as oligodendroglioma. Suppose there is partial deletion of 1p or only 19q, then the tumor cannot be called as oligodendroglioma. Just to give you a few examples, so here we have one diffuse astrocytoma which has more of protoplasmic and fibrillary astrocytes. Here we have a gemistocytic astrocytoma. So based on what I have told you till now, the first step is histology. The second step we do IHC with IDH, ATRX and P53. So morphologically this is astrocytic. On immunohistochemistry, the tumor cells are showing cytoplasmic positivity for IDH. There is ATRX loss of expression which tells us that this is indeed a astrocytic tumor, and P53 supporting the P53 positivity supports ATRX loss of expression. So this tumor will be astrocytoma, IDH mutant, grade 2 or grade 3 depending on the mitotic activity and MIB1 labeling. Similarly, here we have a classic oligodendroglioma with nice thin-walled capillaries and cells having perinuclear halo. So when we do IDH, ATRX and P53, what happens in these tumors? This is IDH positive, indicating that there is IDH1 or 132H mutation. But since this is an oligodendroglioma, there will be ATRX retained expression, unlike astrocytomas where we see loss of expression. And P53 is generally negative in any oligodendrogliomas. But only IHC will not be sufficient to diagnose this tumor as oligodendroglioma. We need to show co-deletion of 1p and 19q. So once we are done with all these, we can call this tumor as oligodendroglioma IDH mutant and 1p19q co-deleted, and the grade depending on our mitotic activity. So what do we do when we have something like this, where we have both astrocytic phenotype as well as oligodendroglial phenotype? WHO strongly recommends that we should not be using this terminology of oligoastrocytoma NOS, because once we do all the molecular testing, the tumor will either fall into an astrocytic lineage or it will go into oligodendroglial lineage. However, there is a slight chance that all the molecular testing may not be possible at all the laboratories or at all institutes. So still the WHO has retained the terminology oligoastrocytoma NOS. In these cases, I have put an example here where we have done IHC. IDH1 is positive, but ATRX is retained and P53 is negative. And I suppose I do not have facility to do FISH. then this tumor will still remain to be Oligoastrocytoma, NOS, until we do FISH and show either co-deletion or retained status. This tumor cannot be further classified. So this terminology still holds good at many places. So what have we learned till now? In any lower grade diffuse glioma, that is diffuse glioma of grade 2 or grade 3, histology forms the foundation, and basic IHC markers that we need to do, in addition to GFAP, OLIG2, we need to do IDH, ATRX, P53 and MIB. Cases where histology and immunohistochemistry favor diagnosis of oligodendroglioma, 1p19q co-deletion status has to be assessed. So what are the platforms that we require for doing these tests? For detecting most of the IDH mutations, we can go for IHC, and ATRX P53 MIB also can be performed on IHC. Suppose IDH1 R132H is negative on IHC, then to detect rare IDH1 and 2 mutations, we need to do PCR and sequencing. Cases which are suspected to be oligodendrogliomas, we need to do FISH for detecting 1p19q co-deletion. So till now I have told you only about IDH mutant tumors. When do we call any diffuse gliomas IDH wild type? So to call any diffuse glioma as IDH wild type, in addition to showing negativity for IDH1 R132H on IHC, we should also rule out rare IDH1 and 2 mutations by PCR. So until and unless we do that, we cannot declare a tumor as IDH wild type. So we've all been talking about a lot of IHCs, moleculars in the form of PCR, FISH. What happens if I do not have access to any of these molecular testing? What do I do then? Should I not report a tumor at all? That's not possible. So after the 2016 classification, a consortium has been formed which is coming up with updates which are periodically released in brain pathology. So these updates kind of act like a vehicle between the existing 2016 classification and the upcoming 2021 classification. Till now 7 updates have got released, and I think you have also been introduced to this in your previous lectures. So we'll just try to apply to this lecture whatever is feasible. So C-Impact Now Update 1, what it did is it defined 2 terms. One is NOS and the other is NEC. NOS stands for Not Otherwise Specified. NEC stands for Not Elsewhere Classified. So when do we use these terminologies? We use NOS when the molecular testing which was supposed to be done for diagnosing the tumor is not at all available. We have not been able to do. We are just going by the histological, morphological diagnosis. If I have seen an astrocytoma on histology and I want to call it astrocytoma, I can go ahead and call it diffuse astrocytoma, NOS, WHO grade 2. On the other hand, NEC is used when I have the facility to do the moleculars and I've done the molecular diagnostic testing, but the results which have come out of the testing do not conform to any known or a described WHO 2016 entity. For example, I have a histological oligodendroglioma. I have done IDH mutational studies. I have also done FISH for 1p19q co-deletion. But this tumor is showing IDH mutation. It is showing 1p deletion, but 19q is intact. What do I do in such a condition? Such a state, we will call this tumor as diffuse glioma, IDH mutant with 1p loss, 19q retention and NEC. So the basic difference between NOS and NEC is, in NOS you don't have the access to molecular testing, you have not done it at all. NEC you have done the test, but then they do not give you an end result which is according to the WHO 2016 classification. So that is about C impact now update 1. Relevant to our diffuse glioma topic is C impact now update 2. There are two subparts to it, but I will be talking about only one here, which is relevant to diffuse glioma. Actually, in the 2016 WHO edition, which was released, if you remember the flowchart I showed you, it said that 1p19q co-deletion should be performed for all diffuse gliomas, which are co-deleted becomes oligo and which are non-co-deleted becomes astrocytoma. But later, the C impact now update 2 gave us this good setting where if a glioma is either grade 2 or grade 3 diffuse glioma, we have done IHC and we have shown IDH positivity. We have also shown loss of nuclear expression for ATRX. With or without strong diffuse P53 positivity, we can directly call it astrocytoma without any need for doing 1p19q testing. So if a tumor is showing ATRX loss, like how I showed you a few cases, we can directly go ahead and call it astrocytoma. We don't need to take the burden of doing additional FISH testing for 1p19q co-deletion. So that is what the C impact now update 2 said. So till now we have seen all the lower grade diffuse glioma. Let's now move on to the most malignant tumor, which is glioblastoma. So glioblastoma, in addition to being an astrocytic tumor showing cellular atypia and mitosis, is characteristically diagnosed based on presence of palisading or geographic necrosis with or without microvascular proliferation. So these morphological pointers are common to glioblastoma, whether it is in older adults or it is in a young adult or pediatric population. But we are into this molecular era, and we know that molecularly they are two different groups. In older adult we have IDH mutant, IDH wild type and the not otherwise specified category of GBMs. On the other hand, in the younger group, we have, along with IDH mutant and the wild type group, we also have histone mutant tumors and BRAF mutant tumors. These tumors can also occur in older adults, but they are predominantly seen in younger populations. So we will try to look at these two groups separately. First, let's look at the adult glioblastomas. So I told you there are two groups in adult glioblastoma. One is the IDH wild type and the other is IDH mutant. IDH wild type is nothing but what was previously called as primary glioblastoma, and IDH mutant are the ones which were previously called as secondary glioblastoma. How are they different? When you look at moleculars, you can see here that in IDH wild type glioblastomas, you have a higher percentage of third promoter mutations, EGFR amplification and PTEN mutations. Whereas your IDH mutant glioblastomas are similar to astrocytomas that we saw till now. They have high percentage of ATRX and P53 mutations, which is what we saw in astrocytic tumors. So, now there is a new proposed terminology to call these IDH mutant glioblastomas as IDH mutant astrocytomas because they are similar to astrocytomas. Only thing is that they are higher grade tumors. So, what is the proposed terminology now? To call it as IDH mutant astrocytoma, WHO grade 4. This diagnosis is not only based on histology. So if we have a tumor astrocytic which shows microvascular proliferation or necrosis and IDH mutation, we call it IDH mutant astrocytoma, WHO grade 4. But there is an additional molecular feature that has been introduced. Suppose I have a tumor which on histology just shows grade 2 or grade 3 features. Does not show microvascular proliferation or necrosis. But when I do a molecular testing, I can find that this tumor shows CDKN2A2B homozygous deletion, then also the tumor becomes WHO grade 4. So it's very important for us to remember this new additional feature that has been introduced. How do we detect this CDKN2A2B homozygous deletion? Again, fluorescence sensitive hybridization is a good technique to identify this. green being again the control probe and red signals being the test. So you can see that many of these nuclei do not have red signals at all, indicating that there is homozygous deletion of CDKN2A2B. Suppose this tumor was a grade 3 astrocytoma on histology and showed IDH mutation, but on FISH it is showing CDKN2A2B deletion, then this tumor becomes a grade 4 astrocytoma. So that is the significance of doing this test. Now let's move on to IDH wild type GBMs. In diffuse lower grade glioma, I said to call any tumor as IDH wild type, we need to demonstrate even absence of rare mutations by doing sequencing in addition to showing negativity on IHC. In wild type GBMs, there is slight modification. If the patient is less than 55 years, we have to do sequencing. Suppose you have a patient who is 55 years and above. Then there is no need to do sequencing, just demonstration of IDH negativity on IHC alone is sufficient. Why is this difference? Because literature has shown that the frequency of rare IDH mutations in patients who are older than 54 years is less than 1%. So it is practical to just go by IDH negativity on IHC in a patient who is 55 years and above, and the diagnosis is IDH wild type GBM. Okay. What are the other important molecular markers that one needs to look at in glioblastoma? In addition to performing IDH mutation, the other very important test that we need to do is Mgmt promoter methylation. So Mgmt promoter methylation, what is this? We all know that in patients with glioblastoma, they are all treated with a chemotherapeutic agent called as temozolomide. What does this temozolomide do? It causes addition of this methyl group to guanine. Okay, so whenever this methyl group is added, there is a double-stranded DNA break that happens. So the cell undergoes damage and dies. If Mgmt is active, it tends to repair this break and so the cell doesn't get degraded. However, when the Mgmt is methylated, this activity of repair doesn't happen. So temozolomide is active. Whatever it causes damage to the cell is still damaged, and that is why the chemotherapeutic agent will act better if the tumor is having Mgmt promoter methylation. This Mgmt promoter methylation can be seen in glioblastomas as well as oligodendroglioma. In oligodendroglioma, the frequency is very high, almost 100%. That may be the reason why these patients respond very well to treatment. Next, we see them in almost 90% of IDH mutant glioblastomas as well. Whereas in IDH wild type GBMs, the frequency is low, about 40 to 50%. So, how do we detect this Mgmt promoter methylation? There are several techniques. Some of the important ones being methylation specific PCR. This will just tell us whether it is methylated or unmethylated. It will not give us a quantitative result. Whereas if we do a real-time PCR, it will give us a quantitative result and we can draw a cutoff. So these are some of the commonly used methods to detect Mgmt promoter methylation. Why is Mgmt promoter methylation important? I told you because of its prognostic significance. So how does management vary? It mainly becomes important in older patients and especially who have poor performance status. In such patients, if Mgmt is methylated, only temozolomide will be given and radiation is not required. Whereas if the patient is having Mgmt unmethylated status, only radiation therapy will be given without giving the chemotherapy. So just to reduce the burden of toxicity of these treatment. Next important molecular alteration in glioblastoma is EGFR amplification, not only in glioblastoma, in any IDH wild type higher grade tumors. So EGFR amplification is primarily seen IDH wild-type glioblastomas, about 40% of them show EGFR amplification. Again, the technique used to identify EGFR amplification is fluorescence in situ hybridization. I think many of you will be familiar with EGFR amplification because of its involvement even in lung tumors. The next important molecular alteration is third promoter mutation. So third promoter mutations like your Mgmt can again be seen in oligodendroglomas as well. But here there is a difference, slight difference. What is the difference? When we see third promoter mutation in glioblastoma, these tend to have very poor prognosis, whereas third promoter mutation in oligodendroglomas are having good prognosis. So here we limit our discussion to glioblastoma. In oligodendroglomas, we do not do, or it's not essential to do third promoter mutation. However, in glioblastoma or IDH wild-type higher grade gliomas, we need to look for third promoter mutation. Here, we need to do sequencing and identify presence of this heterozygous mutation. So why are these important? I have been telling you that EGFR amplification is important, third promoter mutation is important for higher grade glioma. Why? Because this C-impact now update 3 will explain to you. So the C-impact now update 3, what it recommends is that any diffuse astrocytic glioma, be it grade 2 or grade 3, if it is IDH wild type and shows one of these molecular alterations, EGFR amplification or third promoter mutation or whole chromosome 7 gain with chromosome 10 loss, if any of these is present in an IDH wild type astrocytic tumor, it automatically gets upgraded to glioblastoma WHO grade 4. If you remember in IDH mutant astrocytic tumor, I said presence of CDKN2A to be homozygous deletion upgrades it to astrocytoma grade 4. Similarly here, presence of EGFR amplification or third promoter mutation or the chromosome 7 gain 10 loss will upgrade a grade 2 or grade 3 IDH wild-type astrocytic tumor to glioblastoma grade 4. So that is the significance of doing these, testing for these molecular alterations. That was about adult glioblastomas. Now let's move to the young adult and pediatric glioblastomas. So in these patients, these are the important molecular alterations that we need to look at. That is BRAF mutation, IDH mutation and histone mutation. BRAF mutant tumors have a classic morphology. If you see these cells here in this entire tumor, you can make out that they are more plump, rounded. They don't look like glial, rather they look more epithelial. So these are called as epithelioid cells and they tend to produce what are known as papillary structures. These are more surface located and these are the tumors which show BRAF mutation. This BRAF mutation is V600E and luckily we have an immunohistochemical marker to detect this, which tends to produce a cytoplasmic positivity in tumor cells. So these are common in younger patients and we can detect by using this simple immunohistochemical marker. But please remember that BRAF V600E mutation is not specific and not seen only in epithelial glioblastomas. It is seen in a whole range of CNS tumors. In addition to epithelial glioblastomas, we can also see it in pleomorphic xanthostrocytoma. We can see in a whole lot of glioneuronal tumors and also in craniopharyngiomas, papillary type. So it's not a specific marker only for epithelial GBM, but if we have a morphological diagnosis of epithelial glioblastoma, BRAF V600E helps us in identifying the mutation. That's all. Now let's move on to the histone mutant tumors. Amongst the histone mutant tumors, we have two types. One is what happens in the midline, that is in the thalamus and pons. These are the H3 K27M mutant tumors. Then we have what are seen in the hemisphere. So these are the H3 G34 R/V tumors. So in the midline you have H3K27M. In the hemisphere you have H3G34Rb. What about this H3K27M mutant tumors? Why are they important? They're important because it is defined by this molecular alteration. Any midline glioma that is in the thalamus, brainstem or spinal cord which shows H3K27M mutation is always WHO grade 4, whatever be the grading on histology. However, there is a small problem here. We should not call a Spilocity Gastrocetema or an Ependymoma which can be showing H3K27M mutation as diffuse midline glioma. It should only be a grade 2 or a grade 3 or even grade 4. It should be a diffusely infiltrating glioma. It must be in the midline, either thalamus, brainstem or spinal cord, and it should show H3K27M mutation. How do we identify this mutation? We have again a specific immunohistochemical marker which will come positive in the nuclei of the tumor cells, and this is how we can identify the mutation. On the other hand, in cerebral hemispheric glioblastomas, we have H3G34Rb mutant tumors. These tumors have distinct morphology. They can resemble glioblastoma, they can resemble gliomatosis cerebri, they can also resemble a peanut, that is, they can have just undifferentiated embryonal tumor-like cells. So these are different morphological patterns that this tumor can show, and we can identify them by either doing sequencing or recently a immunohistochemical marker has also come up for this H3G34Rb mutation. Unlike the K27M mutant tumors which have a very poor prognosis, the G34Rb tumors have an intermediate prognosis. They are most often associated with ATRX and P53 mutation. If you remember earlier in the lecture, I told you that tumors with ATRX mutation can be either astrocytic or they can be the histone mutant tumors. So this is about the histone mutant tumors. We have two types, midline K27M and hemispheric G34Rb. So to summarize, what are the molecular alterations, different methods and their role in diffuse glioma, be it grade 2, grade 3 or grade 4. Most important is Idh mutation, which can be identified by immunohistochemistry or sequencing. They do have diagnostic and prognostic role. Therapeutic trials are ongoing for targeted therapy. For ATRX mutation, a simple IHC is useful. It can be diagnostic of an astrocytic or a histone mutant tumor. 1p19q co-deletion needs FISH testing. It has diagnostic, prognostic as well as predictive roles. Histone mutations can be identified again by IHC or sequencing, and they are diagnostic as well as prognostic. BRAF V600E mutation can be identified by IHC. It helps us in confirming certain diagnosis and also can be used as a therapeutic marker because several targeted therapies are upcoming. Then about EGFR amplification, it is diagnostic in GBM Idh wild type. It can be identified by FISH. Third chromatomutation can be identified by again sequencing. Mgmt Chromatometallation is a very important molecular alteration that we see in GBMs, and there are different PCR methods to identify this. It has prognostic as well as predictive role. So after knowing this, we need to see how we use these molecular markers. I've already told you all this, but a simple summary of approach. A basic approach, how we see as a pathologist, how we approach a diffuse glioma, which could be of grade 2 or grade 3. First and foremost, we'll see whether the tumor is Idh mutant or negative by IHC. The next step will be to look at ATRX supported by P53. If a tumor is Idh mutant, ATRX lost, automatically it becomes Astrocytoma Idh mutant. And it can be grade 2 or grade 3. But the new knowledge that we have acquired says that in Astrocytomas Idh mutant we need to do CDK and deletion to look for any upgradation of this tumor to grade 4. Suppose ATRX is retained, then we need to do FISH to see if there is co-deletion and call it oligodendroglioma. Non-co-deleted could be still an astrocytoma, Idh mutation. Similarly, for the Idh negative cases, if ATRX is retained, FISH for oligodendroglioma. Suppose ATRX is lost, it becomes a astrocytic tumor, but we still don't know whether it is Idh mutant or has rare Idh mutations or it is really Idh wild type. So then we need to do Idh sequencing. By that it could be Idh mutant astrocytoma. Again we need to do CDKN2A. If it is Idh wild type, then we need to assess clinically whether the patient is young. If he is young, then we need to look for Histone and Idh mutation. Same Idh wild type tumor, if it happens in an older adult, then we need to check for EGFR, TERT and chromosome 7 gain 10 loss to check whether it falls into the Idh wild type glioblastoma group. So here, if a tumor has oligodendroglioma like look, it is Idh negative, FISH is also non-co-deleted, then please remember that many tumors can mimic oligodendroglioma. You can have clear cells, even low-grade pilocytic astrocytoma, DNET, lot of glioneuronal tumors can have areas which look like oligodendroglioma. So it's always important for us to go back and look at our morphology. Higher grade gliomas, what do we do if it is midline and Idh wild type, irrespective of it, whether it's grade 2, grade 3, grade 4, even in grade 2, grade 3, if we have midline, we do H3K27M. If it is higher grade also, we have to do H3K27M. If it is positive, we call it diffuse midline glioma. In negative tumors, they are just called Idh wild type GBM. Young adults, similarly, Idh wild type, we need to do BRAF and H3 sequencing to identify these specific tumors. In all the higher grade gliomas, it's important to do Mgmt Chromatometallation. So that is the basic approach that we need to follow for any diffuse glioma as of our current knowledge, which will keep improving and keep changing. So next, let's move on to ependymal tumors. From now on, we can, I think, go faster because we have covered the most important group of diffuse glioma, and you have also already listened to lectures on ependymomas. So in ependymomas, we have grade 1, grade 2 and grade 3. The important molecular entity that has been introduced here is ependymoma rela fusion positive tumor. And to quickly revise this molecular classification, we have site-based classification here. We have 3 subtypes in supratentorial, posterior fossa and spinal. So in supratentorial, we have sub-ependymoma, YAP1 fusion positive tumors, both have good prognosis, whereas the rela fusion positive tumor has a poor prognosis. Again in posterior fossa, we have sub-ependymoma group A and group B. Amongst this group A is poor prognostic one and the other 2 are good prognosis. In spinal ependymomas, we have sub-ependymoma, myxopapillary ependymoma and ependymoma with NF2 mutation. This was the article which was released in 2015. At that point of time, all the spinal ependymomas were believed to have good prognosis. In a short while, we will see whether it still holds true or there is a change. So, we need to identify these poor prognostic groups of ependymomas, which is what we can and we must do at the level of diagnostics. So, in supratentorial ependymoma, we have rela fusion positive ependymoma, which tend to have poor prognosis. This fusion can be identified only by fluorescence in situ hybridization or PCR, but we have a surrogate marker by immunohistochemistry which is called as L1-cap. This is not a specific marker unlike H3K27M or IDH1 or 132H. This is just a surrogate marker which can only indicate that probably this tumor has rela fusion. Okay, it's not specific. So these produce a membrane positivity, and all the tumors which are L1-cap positive or the rela fusion positive have specific characteristics. They're more common in younger patients, that is a pediatric patient. They are more common in the frontal lobe. Morphologically, they tend to have a lot of clear cells, and some may have papillary pattern. And when you do a EMA staining, they have strong diffuse paranuclear dot positivity. Of course, GFAP will show perivascular accentuation. So these are some of the features which help us to identify this group of poor prognostic supratentorial ependymoma. What about posterior fossa ependymoma? I said posterior fossa PFA group is and tends to have poor prognosis. So here we can identify this PFA group, not all of them, but a subset of them can be identified by using an immunohistochemical marker called as H3K27ME3. This is different from H3K27M, which we saw in the diffuse midline glioma. That was a mutant protein. This is a normal protein. It's normally expressed by all the cells. Whenever there is a tumor which belongs to the posterior fossa ependymoma group A, there will be loss of expression. Here you can see that the endothelial cells of the vessels are showing positivity, serving as internal control. In contrast, all the tumor cells are showing loss of expression. So the loss of expression of this particular protein indicates that this posterior fossa ependymoma belongs to group A. Next, moving on to the spinal ependymoma. I told you that according to the 2015 classification, or the classification that was published in Cancer Cell, at that point of time it was believed that all spinal ependymomas have good prognosis. But recently in 2019 a paper was published which did show that spinal ependymoma also has a small group which shows NMIC amplification, and these patients or these tumors behave very aggressively. Among spinal ependymomas itself, the ones which show MICAN amplification have a very poor progression-free survival as well as overall survival. And when you compare with them with the other poor prognostic molecular subgroups like the RELA fusion positive and the posterior fossa A group also, this spinal with MICAN amplification has very poor prognosis. So it's again important for us to identify. For identifying NMIC amplification, we need to depend on FISH. There is currently no available immunohistochemical marker. So when you look at an ependymoma on histology, for diagnostic basically we need to do GFAP, oligo and EMA. I hope you all remember the first few slides I showed you, how these markers are important in diagnosing diffuse glioma versus ependymoma. Once you have diagnosed it, for prognostication, we have to do these. In a supratentorial tumor, we'll do L1 CAM or RELA fusion depending on availability. In posterior fossa, we need to do the H3K27ME3 IHC, and in any spinal ependymoma, we look for NMIC amplification. Let's now move on to other astrocytic tumors. So now the WHO 2016 has categorized all the diffuse gliomas together and separated these astrocytic tumors as other astrocytic tumors because they do not show or they do not follow the Idh mutation pathway. What tumors fall into this category? We have pilocytic astrocytoma, sub-ependymal giant cell astrocytoma, pleomorphic xantha astrocytoma, and anaplastic pleomorphic xantha astrocytoma. The first and very common tumor, especially in younger patients, is pilocytic astrocytoma, which is a WHO grade 1 tumor. It follows the MAP kinase pathway when you look at it molecularly. So the most important alteration in this MAP kinase pathway that we see in pilocytic astrocytoma happens in the BRAF protein. BRAF, till now, whatever you saw in epithelial glioblastoma was the BRAF V600E point mutation. Here, what we are talking about is a different molecular alteration, the same BRAF. Here, what we are talking about is BRAF fusion. So remember, in pilocytic astrocytomas, it is BRAF fusion, which is the most common. Mutations can also happen in about 10% of pilocytic astrocytoma. Other than that, all are BRAF fusion tumors. Okay, pilocytic astrocytomas. So this fusion can again be identified by two different techniques. One technique is fluorescence in situ hybridization. The other technique is real-time PCR. So we can use either of these techniques. Each has its own advantage and disadvantage. It's not essential test to do for pilocytic astrocytoma in the sense it is not like oligodendroglioma where you have to demonstrate 1p19q co-deletion to call any tumor as oligodendroglioma. But as of now, pilocytic astrocytomas can be diagnosed based on just histology alone with its characteristic biphasic pattern. These are just the known molecular alterations in pilocytic astrocytoma. It is not essential for us to carry out these molecular tests. The other astrocytoma is pleomorphic xanthoastrocytoma, which tends to have a lot of pleomorphic cells and these xanthomatous cells, which is why the name given to this tumor as pleomorphic xanthoastrocytomas. They can also show eosinophilic granular bodies, what we are seeing here, and the molecular alteration that is seen in pleomorphic xanthoastrocytoma is again BRAF V600E mutation, for which we have a IHC marker. About 50 to 75% of PXAs show BRAF V600E mutation. Again, it's not seen in 100% of these tumors. When we look at anaplastic pleomorphic xanthoastrocytoma, molecular remains the same. These also show BRAF V600E mutation. The diagnosis is purely based on mitosis cutoff. Any tumor with any PXA which shows 5 or more than 5 mitosis per 10 hapar field will qualify for an anaplastic PXA. So when you look at the moleculars, it will show BRAF V600E mutation. The last other astrocytic tumor group is Sub-Ependymal giant cell astrocytoma. The diagnosis here is also based on clinical features. It's one of the tumors seen with patients having tuberous sclerosis, and morphologically they tend to produce this monomorphic ganglioid astrocytes, which can be arranged either in the fascicular pattern or they can be arranged in papillae. So what immunohistochemical markers do we use for diagnosing or confirming presence of subependymal giant cell astrocytoma? Again, very basic markers which I told you at the beginning of this lecture, GFAP and S100. In all diffuse gliomas, there is generally a diffuse staining pattern for GFAP. But in SEGA, what happens is there will be a patchy and variable staining. Some cells here you can see are very strongly stained, some are not even stained, some are lightly stained. So this kind of patchy staining will be seen with GFAP and S100 will be diffusely positive. One more marker which is recently described in SEGA is TTF1. All of you are very well familiar with this marker, but its role in SEGA has been described recently and we can use TTF1 also to confirm our diagnosis of SEGA. But it is not essential, it's not 100% present in all the SEGAs. So that was about the other astrocytic tumors. They have very little additional molecular alterations at present. They can all be diagnosed with simple GFAP, S100 and BRAF additional molecular alteration that can be seen in a subset of this. BRAF fusion being present in pilocytic astrocytoma, BRAF mutation seen in pleomorphic xanthoastrocytoma. So the last set of tumor is again a very important large group of tumor in CNS which we do encounter. So this is the CNS embryonal tumor group. This is a very nice representation of how the classification has changed from 2007 to 2016. In 2007, you can see that everything is histologically defined, be it medulloblastoma, ATRT or the whole group of CNS PNET. Whereas in 2016, we have a genetically defined as well as histologically defined entities. One thing is very striking with CNS embryonal tumor, unlike diffuse glioma where moleculars and morphology got clubbed into a single defined entity like astrocytoma, Idh mutant, or oligodendroglioma, Idh mutant and 1p19q co-deleted. In embryonal tumor, we have a clear demarcation still existing. We have a histologically defined classification as well as genetically defined classification. So in the histologically defined medulloblastomas, we still have classic desmoplastic nodular medulloblastoma with extensive nodularity as well as large cell anaplastic medulloblastoma. What about the genetically defined entities? We have 4 groups here. WNT activated or the Wnt activated, SHH activated tumors which could be of p53 mutated or wild type, and then we have the non-Wnt, non-SHH which is clubbed together. Next, moving on to ATRT, this is also now molecularly defined. We have to show mutation in INI or BRG1. In case we are not able to show, it becomes a histologically defined tumor, that is CNS embryonal tumor with rhabdoid features. The third entity is embryonal tumor with multi-layered rosette. This is also a genetically defined entity which is defined by C19MC alteration. If we don't show this alteration, then it becomes a NOS category. Then we have the same categories which were there before. They were called as CNS PNET. Now they are no longer called as PNET. Could be medulloepithelioma, CNS neuroblastoma or ganglioneuroblastom. Suppose a tumor does not fall into any of this, then we can just call it CNS embryonal tumor, NOS. So these 4 distinct subgroups of medulloblastoma was identified in a consensus meeting in 2012. Because these 4 molecular subgroups differ in the age groups that they affected and the prognostic role as well as the molecular alteration. Amongst this, the most common is the SHH molecular subgroup and the group 4 subgroup. These 2 are the most common. Wnt has the best prognosis and group 3 has a worst prognosis. Okay. So how do we incorporate this molecular classification in our day-to-day practice? Before that, we also need to know that p53 mutation has a prognostic role in this SHH molecular subgroup. So the p53 mutant tumors tend to have poor prognosis, whereas the wild type have better prognosis. So when we have a medulloblastoma, we use a panel of markers, that is beta-catenin, GAB, YAP and p53. INI is always done to rule out ATRT. So beta-catenin nuclear staining is very important. In a WNT molecular subtype of medulloblastoma, both beta-catenin and YAP1 are positive. In SHH molecular subgroup, GAB1 and YAP1 are positive. p53 plays an important role in this molecular subgroup. When all are negative, we call that tumor as non-Wnt, non-SHH. So when we have histology, why is molecular important? Or when we have molecular subtype, why is histology important? Let's just take one example. Let's take a classic histology medulloblastoma. If it belongs to the WNT activated or the Wnt activated, it is a low risk tumor. The same classic histological medulloblastoma, if it belongs to SHH activated p53 mutant group, then it becomes a high risk tumor. Whereas in all other molecular subgroups, it is a standard risk tumor. So the risk changes with histology as well as molecular profile. Hence the importance given to both the classification systems. So let's quickly look at some of the molecular subtypes cases. Here is a classic medulloblastoma with a lot of humerite rosettes. It is showing nuclear beta-catenin positivity and YAP1 positivity. It's GAP negative. So it belongs to the Wnt activated medulloblastoma. Here we have a desmoplastic medulloblastoma which is highlighted by the reticulin silver stain. This tumor was beta-catenin negative. It is showing nice GAP1 positivity as well as YAP1 positivity. So this belongs to SHH activation. And we need to look at p53 mutation in this group of tumor. This is a large cell anaplastic medulloblastoma on morphology, shows beta-catenin only cytoplasmic positivity, so it is not positive. Only nuclear to be taken as positive. GAP1 is also negative, YAP1 is also negative, so this belongs to the non-Wnt, non-SHH medulloblastoma. Then I talked about Mgmt amplification. So MYC amplification, particularly the N-MYC amplification, is seen in the non-MYC non-SHH, also can be seen in the SHH P53 mutant. So this carries a very poor prognosis, and we need to use FISH to identify this technique. Then we have a newer entity, that is the embryonal tumor with multi-layered rosettes, which has to be identified by presence of C19MC alteration. This is actually a unifying entity for three different morphological patterns, that is the embryonal tumor with abundant neuropil and true rosettes, Epinephrine and Methylation. These three distinct histological patterns were clubbed into a single tumor, which is ETMR. So how do we identify this C19MC amplification? Again, we have a surrogate IHC marker, which is called as LIN28A. The tumors which do show LIN28A can be considered to have C19MC amplification. So morphologically, it can be an etanter, that is embryonal tumor with multi-layered rosettes and abundant neuropil, or it can be a medulloepithelioma. So medulloepitheliomas tend to resemble the primitive neural tubes with a pars positive outer limiting membrane. Both the tumors show LIN28A positivity. Suppose this medulloepithelioma was not showing LIN28A positivity, then it would have remained as a medulloepithelioma itself. On the other hand, suppose this etanter did not show LIN28A positivity, then it will become a ETMR NOS. We can't call it etanter, that is changed to ETMR, and because we're not showing the molecular alteration, it becomes NOS. Next, moving on to the last group of embryonal tumor, which is ATRT. This is defined by alteration in INI1 or BRG1. So if we need to diagnose a tumor as ATRT, we need to show these rhabdoid cells, and importantly show loss of INI1 expression or BRG1 loss in the tumor cells. Suppose we cannot show this, then the tumor becomes embryonal tumor with rhabdoid features, WHO grade 4, we cannot call it ATRT. To summarize what we need to use in any embryonal tumor, we have to basically use phenactophysin, INI1 and LIN28A as diagnostic markers. To subtype medulloblastomas, molecularly we use beta-catenin, GAP1, GAP1P53 on IHC, and monosomy 6 and MYC amplification can be identified by FISH. All these have prognostic significance. So we have looked at very basic immunohistochemical markers. Most of the moleculars, luckily, we can use either targeted specific antibodies, or we can use the surrogate markers like LIN28A or L1CAM. And in some situations, we have to depend on FISH, for example, to detect 1p19q deletion or to look at EGFR amplification. And the third technique which we have commonly seen is sequencing, PCR followed by sequencing for rare Idh mutation, third promoter mutation or histone mutations. So these are most commonly widely used techniques. However, the most recent technique that has come up and which was published in 2018 is the DNA methylation based classification of CNS tumors. Capper and his colleagues have classified about 2,800 tumors based on the DNA methylation profile of these tumors, and they have come up with several molecular groups, subgroups within already existing groups, and this is ever expanding. I'm not going into details of this as we are not practically applying the methylation based classification, but one needs to know that in the future several of the classifications of CNS tumors is probably going to be based on this methodology. So with that, I would like to end the session by saying that molecular biomarkers have indeed gained major importance in the classification of CNS tumors. Although immunohistochemistry is the most feasible method, wherever mutation-specific antibodies or surrogate markers are available, we can go ahead with immunohistochemistry. But in many cases, a more advanced molecular assay is becoming more and more necessary as our knowledge regarding the CNS tumors is improving. We as pathologists need to keep in pace with all these advancements, and we need to develop techniques which are feasible and practical for us to use for diagnosing as well as prognosticating the CNS tumors in our day-to-day practice with whatever resource limitations we have. So, thank you. Any questions? I will be happy to take.
Thank you, Dr. Shilpa Rao. Excellent presentation. And you went very well, very confidently, very slowly, and explained everything. And definitely we fall into the NOS category and you fall into the NEC category. Absolutely true. And yeah, true. I mean, with my experience and my knowledge about how the pathology setup is in the entire country, I think the majority of us would be the NOS, and a very small part of it would be NEC.
That's good.
And then you would be the top of the NEC group. Yeah, if you have your phone with you, I have WhatsApped you the questions which are on the YouTube. Do you have your phone?
Yeah.
Then you can check up on the WhatsApp. I mean, you will find all the questions on the YouTube, and you can take them one by one.
Yeah. Dr. Minesh Gandhi has asked how to pick up granular cell astrocytoma in biopsy and how IHC will help it out. So granular cell astrocytoma is basically a histological based diagnosis. IHC would not play an important role in that, other than just telling you could use a GFAP to confirm that it is indeed an astrocytic tumor. How do we identify that on histology is they'll have an intense eosinophilic cytoplasm which will have coarse granules. You can also use simple special stains like PAS, that is the periodic acid skiff, which all the laboratories will be having, and these granular cells will take up positivity. The importance of identifying granular cell astrocytoma is they tend to behave bad, they tend to progress into GBMs faster, and they have a poor prognosis. So that is mainly histology based pickup, and IHC does not play much role in identifying this. So he has asked another question, how to differentiate DNET from multinodular vacuolating tumor in biopsy and how IHC helps in this type of case. Okay. So again, morphology forms an important role. Basically, DNET will have clear cells which are almost resembling an oligodendroglial cells, and they have a distinct pattern of arrangement. What is this distinct pattern of arrangement? The tumor cells will be arranged in the form of columns, that is one below the other, and on either side of this column we'll have axonal processes. So it will be like a row of cells which are arranged and they will be perpendicular to the cortical surface. And you also see what are called as floating neurons in a DNET. When you look at a multinodular vacuolating tumor, the cells are larger in size than what we see in a DNET. They also have perinuclear vacuolation, what you see in DNET, but the cells are larger in size. And the third point is, when you do immunohistochemical marker in DNET, the cells themselves will not pick up anything other than S100 and OLIG2. However, if you use a simple synaptophysin or a neurofilament stain, the pattern of columns are better appreciated by using IHC. And even multinodular vacuolating tumor also will show positivity for OLIG2. Both of them will show positivity for OLIG2. So it's again a histology based diagnosis which can only be confirmed on IHC. Most of the glioneuronal tumors are histologically defined. That was Any rhabdoid tumor with 80% INI loss, then what tumors actually they are in your experience, because we use term CNS embryonal tumor with rhabdoid differentiation. So if it is showing 80% loss, then most probably it is a tumor which is showing INI mutation, and it will become a atypical teratoid rhabdoid tumor. Generally, we don't see tumors which show 80% or 70% or patchy loss for INI. INI is generally lost all or none. Suppose there are some normal entrapped cells, those could be the 20% which are showing retained INI1 status. And in those conditions, you should go ahead and call it atypical teratoid rhabdoid tumor. Only if you see retained status in almost all the cells will you call it CNS embryonal tumor with rhabdoid features. I think those are the questions we have.
Yes, those are the questions. That's all, I think.
Yeah.
And there is a half a minute delay between transmission as of now. Probably there's a lot of
Okay.
internet activity going on. Just let's wait for a minute to see if there is any further questions on your clarification.
Sure.
Yeah, just a minute.
Yeah.
Saturday this time generally internet is really heavily loaded.
All of them are used.
Yeah, true.
Weekend.
Yeah, true. Yeah, there is none. There are none any, and there's no questions anymore. So
Okay.
thank you, Dr. Shilpa. Excellent presentation. I'm so honored that you came on this channel and you took time out to speak on this Saturday evening. You know, it must be your weekend and with your busy schedule going on. Thank you so much. God bless you. Take care.
Thank you so
I
much.
think we'll see you on the slide seminar
Yes,
in
yes.
the next, right? Take care. Bye-bye. Good night.
See you all. Good night. Bye.
Yes, please share the PDF of this presentation so that we can share it in the group.
Okay, sure. Okay.
Yeah, right. You can send it on my email, right?
Sure.
Thank you so much. Take care. Bye. Good night.
Good night.